Hi, everyone. I'm Andrei Iagaru. It's a great pleasure to be part of your meeting, and thank you for the invitation to the organizers and the sponsors. I'm going to talk to you today about a bright future for nuclear medicine, focusing beyond Theragnostics on what else is out there for us in nuclear medicine. So first, just a little diversion here. Why do I use a G? Well, I don't speak Greek, but I tend to believe in what the professor of linguistics at the University of Athens is telling us, that Theragnostics with a G is the better term. So I don't want to start a debate here, but that's the reason why I'm spelling it with a G. Also, from the get-go, I just want to acknowledge a fantastic mentor and scientist and nuclear medicine scientist, and I would love to say friend, Professor Rodney Hicks from Peter Mac, who influenced generations of nuclear medicine and other researchers. And perhaps one of the most important pieces is how he encourages us to move beyond lumpology. We're not just counting lumps, we're doing more to our patients. So Professor Hicks, an honor to know you, and thank you for all your support over the many years. I would also like to get out of the way from the beginning how successful you are in Australia. And I think that this success is a result of the very strong collaborations between the many scientists and Dale, Jiting, Andrew, and Luis and Michael and many others. I apologize for those who I don't have your pictures to post there, but obviously the academic environment in Australia is fantastic. And of course, there's a lot of private foundations and government support and industry support. So it seems to me from the outside that you work so well together, and this is a reason for the fantastic success that you are bringing to our field. So thank you for that. I'm going to start with a few words about Stanford University. This is the main entrance to the campus, the Memorial Church. Stanford was started in 1891 by a very sad event. The very young son, a teenager of the Stanford family, died after a trip to Europe. And the family decided to donate money initially to Harvard, but they would not put their name on a building. So they wanted to build a university on their land in Palo Alto. And as life goes, New York Times named Harvard a few years ago the Stanford of the East. So go figure. But Stanford is a fantastic institution. This is the medical campus with the new hospital that opened in November 2019. And all of these are medical and School of Medicine buildings. And in the background, you can see the law school and engineering school and chemistry school and the Hoover Tower as well. This is all land that belongs to Stanford University. As far as facts, as I said, opened in 1891 after being established in 1885. You can read through this. There are 7 schools. Stanford takes pride in a very low ratio of students to faculty, 5-1, which means we dedicate our time to our students. There are currently 20 Nobel laureates working at Stanford, and since the founding, there were 35 Nobel Prize winners. Also, if you're familiar with the United States academic environment, athleticism is important. And I would like to highlight there are 296 Olympic medals won by 177 Stanford-affiliated athletes. So just think about that. How many of the US Olympic medals have been won by Stanford athletes? And then on the right here, there are many companies that you probably were using on a daily basis, and there are tens of thousands of companies that have been spun off out of Stanford. So we take pride in the entrepreneurship of the academic environment where we work at. The School of Medicine was initially founded in San Francisco, but it moved to Palo Alto in 1959. And this is the original hospital complex built then to be kind of an NIH of the West Coast. And then you can see over the decades how much it grew. It's the same Welch Road here. And in 2022, very busy. A lot of buildings have been put together since then, and it's a great space. I hope that you will come visit us. Like many other institutions, we are growing in the space adjacent to the main campus. So we have facilities in various locations throughout the Bay Area, and nuclear medicine is present in all of them. So nuclear medicine, what is the history of nuclear medicine at Stanford? The one who founded it is Professor Newell, who in 1947 resigned as the head of the Department of Radiology to accept this newly created professorship of biophysics and organized the first facility at Stanford for the medical application of radioactive isotopes. It is documented that he coined the name nuclear medicine, and he invented a lens for use in nuclear medicine that is now the focus collimator. He received the gold medal of the American College of Radiology for his many contributions. He was followed by Dr. Joe Chris, who took over the division leadership in 1957. He's very well known for his contributions to the Graves' disease pathology, showing that it was caused by an antibody. He worked with Sarah Donaldson in radiation oncology to treat eye disease associated with Graves' hyperthyroidism, and was one of the first physicians to use computers in medicine in the 1970s. He was also an artist, and this is one of the many art pieces that he left behind, computer-generated art. We're very grateful that part of this art is on display at Stanford. And of course, there are a few others we're very proud of. Dr. Ross McDougall, the world expert in thyroidology, anything related to thyroid. Dr. Bill Strauss, very well known for his work in cardiac nuclear medicine. And of course, Sam, our dear friend and mentor, whom we lost recently, but who really created a renaissance, not just for the field worldwide, but particularly for us at Stanford. Sam's arrival in 2003 coincided with the establishment of the radiochemistry facility, the first cyclotron, the Clark Center that houses the molecular imaging program at Stanford, MIPS, the largest preclinical imaging facility in the world, and in 2010, the opening of the new nuclear medicine and molecular imaging clinic. I'll come back to this. Of course, over time, we experienced a lot of growth, just like our entire healthcare system. So you can see the numbers growing 4 times higher for PET, more than doubling for general nuclear medicine studies, fantastic growth for bone densitometry as well as for therapies. So over the past decade and a half, we almost tripled our volumes, and I think that this will continue with the advances of Theragnostics. So where are we focused on? We're focused on the cancers that are relevant to patients, and in the interest of time, I'm going to focus on what we do for prostate cancer. Prostate cancer continues to be the #1 cancer in the United States and the #2 as far as deaths per year. So this is a very clinically relevant healthcare issue that we need to address. And of course, we're fortunate in nuclear medicine that our armamentarium includes PET-MRI, PET-CT, SPECT-CT. All of these are tools that allow us to improve the diagnosis as well as the treatment of patients with prostate cancer. And I adopted this graph from the literature. It shows a long course of prostate cancer related to the PSA levels. And I think that at the beginning, there's no doubt that if you have access to PET-MRI, biopsy guidance, initial staging should be done with PET-MRI. Following that biochemical recurrence, PET-CT will play a significant role. And then as we move down the road into more advanced disease where our radioligand therapies are approved, both PET-CT and SPECT-CT will play a role. You are all very, very familiar with prostate-specific membrane antigen. I'm going to touch briefly on that, but I'm going to focus most of my talk on the gastrin-releasing peptide receptors, because I do believe that no matter how good PSMA is, GRPRs will play a role. This is a protein that's overexpressed in a variety of major cancers, including prostate cancer. The world has decided that we need to work with antagonists, not with agonists. The agonists are not only creating a lower signal, but also they lead to adverse events when administered, even in the micromolar dosages for PET imaging. This is a great example from a group in China showing an antagonist versus the agonist. The antagonist is RM26, so it's a bone scan in a patient with breast cancer, and it's unremarkable. However, at the top, there are multiple bony lesions that are only identified with the antagonist and not seen with the agonist at the bottom. So it's a good study because every patient enrolled had both the agonist and the antagonist GRPR, and it showed that only the antagonist is able to identify disease. So let's forget about agonists in this area. Let's stay focused on the antagonist. And this is what the field has done. There are several structures and classes of these compounds that have been put into humans. At my institution, most of the experience with the gallium-68 labeled RM2, but I want to acknowledge the others that have been used in humans as well. Our work has been featured on the cover of the Journal of Nuclear Medicine and includes several studies, including the first pilot study comparing bombacin against PSMA in patients with biochemically recurrent prostate cancer. So why do we bother with GRPR? Of course, it's not just a biology. Even if all things are equal, the biodistribution is different between the two. So you can see here on the left, the two FDA-approved radiopharmaceuticals in the US targeting PSMA, PSMA11 and PyL, uptake in the lacrimal and salivary glands that does not exist on bombacin. There is hepatobiliary clearance, including clearance to the bowel, the renal cortex binding that does not exist with bombacin. And of course, with bombacin, you have the high uptake in the pancreas, but the pancreas is radio-resistant, and it also does not retain the signal over time, which is something I'm going to share with you later. So starting in the course of prostate cancer, let's see how we use bombacin at biopsy guidance. This is the protocol where we take patients with a negative or equivocal MRI, but rising PSA or high PSA density, and they undergo PSMA 11 and RM2 per MRI, and then based on the PET signal, they get biopsies. So far in this pilot study, we enrolled 12 participants, and you can see the clinical features of this small cohort, as well as what we did for imaging. Bottom line, out of these patients, we identified 13 prostate cancer, of which 7 were clinically significant. With PSMA 11, there were 4 that were clinically significant. With RM2, 7 that were clinically significant. So it is important to realize, just like many others have shown, that the distribution of the two classes of radiopharmaceutical is not congruent. There is incongruent uptake between PSMA and bombacin. It's an example here. At the top, you can see the signal from RM2 at the bottom. I'm sorry, at the top from PSMA 11, at the bottom from RM2. Here in panel C, you can see the green dots is the blind saturation needle biopsies that missed the cancer, highlighted in red. The cancer was identified based on the PET signal from RM2 and PSMA. We're also using a similar approach to guide high-intensity focused ultrasound. This is a localized treatment. You don't treat the entire gland. You only treat what you know to represent cancer. So it's important to be fully aware of the full extent of disease. So the same approach, we do PSMA and RM2 per MR before, as well as 6 months after high-intensity focused ultrasound. 2 goals: to more precisely identify disease for treatment, also to attempt to eliminate the need for biopsies at 6 months or later after topical focal treatment. 14 patients so far have been treated in this pilot study, proof of concept. You can see their clinical characteristics here. These are the sensitivities of specificities, and don't be surprised by the low sensitivity of MRIs. This is something that we on purpose screen for. We want to enrich our population with those patients with not a lot of known disease from MRI. This is the first patient ever that was enrolled in this study. So the biopsy tracks in green, the benign tissue in red, the clinically significant cancer in orange, the non-clinically significant cancer. And the clinically significant cancer has uptake prior to HIFU on both bombacin as well as on PSMA. And that uptake has resolved 6 months later, so no need for biopsy here. These findings correlate with a decrease in PSA numbers. There's now post-treatment uptake on the left side of the prostate, and that turned out to be on biopsy a non-clinically significant grade 3+3 prostate cancer. We have the same approach for high-dose rate brachytherapy. Again, we do RM2 and PSMA per MRI prior to brachytherapy, and then 6 months later. It's a very nice example of a biopsy-proven lesion in the right lobe of the prostate prior to HDR brachytherapy, and then 6 months later, the signal is gone. There's no active disease. The next point in the course of patients with prostate cancer is, of course, diagnosis of prostate cancer, intermediate or high risk. These patients are undergoing prostatectomy. We wanted to see how bombacin is performing in this cohort. We enrolled 41 patients here, and these are the SUV measurements, the semi-quantitative measurement, and you can see that they are statistically significant between prostate cancer and nodal metastasis, prostate cancer and benign prostate tissue, nodal metastasis versus benign lymph nodes. So it appears that the uptake can be an indicator of whether you have cancer or not. These are some examples, and I want to acknowledge the very nice work that our colleagues in urology and pathology are doing. They create a 3D mold of the prostate based on the MRI. The prostate is taken out in one piece, put in this 3D mold section, marked for cancer, and then these slices are scanned into packs. So you can review PET, CT, MRI, pathology on packs and correlate your imaging and histological diagnosis. So here, anterior aspect of the prostate, very high signal, correlates with a cancer that crosses the left and the right lobes of the prostate gland. The uptake shows to stratify patients between lower PSA and higher PSA and their SUV measurement. So the higher the PSA, the higher the uptake, perhaps an indication of correlation with aggressiveness and bombacin uptake. We, of course, live in the era of PSMA, so you cannot talk about bombacin without mentioning PSMA, and our research is focused on comparing the two as well. So these are the results in a subgroup of this population who underwent both bombacin and PSMA. And you can see here that there was very little concordance. In fact, the agreement between the two was poor. Some patients demonstrated the same lesions, but many of them had lesions that were only found on one and not the other. So this is from the same patient. Top row, nothing on bombacin, but you have a cancer on PSMA. Second row, the opposite. You have the cancer on RM2, but not on PSMA. Third row, a lymph node that was proven to be metastatic disease on surgery, seen on both, and perhaps at the bottom, maybe more conspicuous on bombacin on PSMA, but either way, they were both called positive and they were demonstrated to be as such on histopathology. It's a different patient. You can see the primary in the right lobe of the prostate, high signal on both PSMA and bombacin. However, I would argue that the conspicuity of this pre-sacral lymph node that was proven to be metastatic disease on histopathology was higher on bombacin than it was on PSMA. Here's another example where you have a cancer that is pretty clearly seen on bombacin and not identified on PSMA-11. What about biochemical recurrence? Well, this is where we have most of the data. So we ran a phase 1 study, a phase 2 study, and we just completed last year a phase 2/3 study. This started in 2013, prior to the wide availability of PSMA. So the inclusion criteria asked for biochemical recurrence defined by AUA and astrophoenix criteria, and negative bone scan and negative CT or MRI. We did not include PSMA as eligibility in this study because PSMA was not available at that time, as I just mentioned. And all these patients underwent then the bombacin PET MRI. So we were able to enroll all 100 of the planned participants. This was supported by the Department of Defense IDEA award. The PET was positive in more than 2/3 of the patients, and there was a statistically significant difference in PSA values between those with positive and negative scans. If we look at the positivity rate per different quartiles, just as expected, it goes up from 41% at very low PSA to greater than 88% at PSA greater than 5. So these numbers are comparable, albeit not as high as with PSMA, but maybe we're finding different cancers. And one thing that is very important is that the PSA velocity was statistically significant different between patients positive or negative bombacin scans. So perhaps we are finding patients that have more aggressive tumors, and the false negative bombacin scans are those with less aggressive tumors that should be left alone. A hypothesis, it remains to be tested and validated. We also looked at changes in management towards the end of the study, and 20 patients of these 100 consecutive at the end had questionnaires filled in by their referring physicians pre and post bombacin scans. And you can see here 65% they were either downstaging or upstaging, so a significant number. Here are some examples: tiny perirectal and presacral lymph nodes, but very easy to identify on bombacin in a patient with a very low PSA. This was a very interesting case with a lesion on top of the liver capsule. There was nothing to biopsy at the time. 4 months later, with MR guidance, this was biopsied and turned out to be adenocarcinoma of prostate origin. It's another example with a higher PSA where you can identify multiple bony as well as nodal lesions. Another patient with a PSA of 2.3 with multiple pelvic and retroperitoneal lymph nodes. It's another patient with uptake in the seminal vesicle on the right, as well as some pelvic lymph nodes. Of course, I want to acknowledge the work that has been done in PSMA to standardize interpretation, and we are using the PROMISE criteria at my institution. We wanted to standardize the interpretation of bombacin as well, and we adapted the PROMISE criteria for use of GRPR. The first thing, we looked at more than 150 patients in an atlas of uptake, and we determined what are the normal ranges of uptake in normal tissue and pathological lesions. And then we propose this score of 0 if it's below blood pool, 1 if it's below the GI tract, intermediate if it's equal or higher than GI tract but lower than pancreas, and high if it's equal or above pancreas. So again, trying to adapt the PROMISE criteria from PSMA to bombacin. And just like in the PROMISE criteria, we looked at the prostate bed, lymph nodes, and other lesions, skeleton, other organs, and then we provided the final judgments, whether positive, equivocal, or negative. And you can see here substantial and almost perfect inter-reader agreement. So we feel that this is something that those in the field who want to use bombacin should use. It's easy to adapt, and it provides pretty good inter-reader agreement. Now, what about the comparison of PSA and bombacin at biochemical recurrence? Here are some examples. The patient with right adrenal lesion that is very conspicuous on the bombacin, but easy to miss, of course, not on CT, but on the PSMA PET, because it blends in with the normal uptake and clearance in the liver. Here's an example on the left of bombacin with several bony lesions that have higher uptake than on the corresponding DCF-PYL. And this is just to illustrate the fact that although in many cases bombacin is not overexpressed in bone metastases, there are some patients where it is, and even higher than with PSMA. This is another example where, given the low clearance in the bowel, hepatobiliary clearance, you can identify a retroperitoneal lymph node on bombacin at the top, and this is not identifiable due to the clearance in the bowel, the duodenal uptake on the PSMA imaging. This opposite of this, a negative bombacin multiple bony metastasis on PYL, and this is something that has been documented to occur where the bony metastases lose the expression of the GRPR. This is a summary of our data in 50 participants who had both bombacin and PSMA, 70 lesions seen on both, 7 more on bombacin only, 36 more only on PSMA. Bombacin is also overexpressed in breast cancer, and I want to acknowledge the great work from Louise, who looked at this with a different compound, with a newly diagnosed estrogen receptor positive breast cancer with very high uptake in the primary and no uptake in axillary lymph node that was deemed suspicious on conventional imaging. It's another patient where, in addition to the primary and satellite lesion, a third lesion very close to the chest wall that was missed on MRI was identified with RM2 PET and led to changes in the surgical approach at initial diagnosis. There's, of course, the field of Theragnostics here as well. You can label things with lutetium-177 as well. So if you see it with gallium-68 bombacin, you can treat with GRPR with lutetium labeled bombacin. So again, adapted from the work at Peter Mac, this concept of if you see something, you unlock it, and then you can use either a diagnostic. If you see it, you treat it with a therapy version. There have been a lot of preclinical work demonstrating that the higher the dose of lutetium-labeled bombacin, the better the outcome. Also work that if you combine lutetium-177 bombacin with a radiosensitizer such as rapamycin, you have better outcome. Also showing that there's no damage to the pancreas or the kidneys, which are the dose-limiting organs. The first patient treated worldwide with lutetium-177 RM2 was in Santiago de Chile at Positron Pharma. I want to acknowledge Vasco and his colleagues there. And you can see over time the uptake in the pancreas washes out, while the uptake in the cancer metastases persists. So there's no damage to the pancreas from this treatment. It can be safely given to these patients. Also great work from the group in Rostock demonstrating the dosimetry of lutetium-177 RM2. And this is shown here, the gallium RM2 at the top, similar biodistribution is the lutetium RM2 at the bottom. I think that we need to move to earlier stages of disease. Once you have very advanced disease, I don't think that we should expect the receptor to continue to be overexpressed. So we need to move these bombesin tracers to earlier stages of disease if we are to discover potential benefits of these treatments. Okay, now I'm going to change gear and talk about how I define success for us working in the field of nuclear medicine and theragnostics. And I do think that success, it's at the intersection of having space available, having equipment available, collaborating with others, and the most important thing, having people who are motivated to work together to advance the field. So this is our clinic. As I mentioned earlier, this opened in 2010. As early as 2014, 15, we started thinking about renovating it to adapt it for infusion and therapies. Patients enter here. We have a bone densitometry. We have a portable gamma cameras. Our SPECT-CTs are on one side, a cardiac solid-state camera on the other side, and then 3 PET-CTs here. We have other facilities, but it's the main clinic. This is a satellite radiochemistry here. We have 2 gallium-68 generators and 2 hot cells, in addition to what we do in the cyclotron facility. And this was my colleague and friends, Craig Levine's lab, physics lab, that we decided to turn into an infusion space. And these are the drawings that were done by an architect with input from patients. And I want to acknowledge Josh Mailman for all his help with this. So without closing the clinic, work was done at night. This space was gutted down and rebuilt. And it is now, as you can see it here, there are 4 rooms like this that offer very comfortable care for the patients. We don't have the views to downtown Melbourne as from Peter Mac, but they are a pretty great achievement, in my opinion. We also have space for a nurse practitioner, a medical assistant, and then we have also 2 restrooms in the back here. At the same time, the hospital buildings from 1989 are being renovated, and we convinced the hospital to invest into 3 new lead-lined rooms for inpatient diagnostics. This entire space will become a cancer hospital, and nuclear medicine is on the 2nd floor here, adjacent to it. So we're in a great position to continue to serve our patients. These are the lead line. One, it's a very heavy lead line room that will allow us to do high activity iodine-31. The other 2 will allow us to do all the other therapies that may require admitting these patients. At the same time, in collaboration with SNPs, with the molecular imaging program at Stanford, we took over parts of this building. It's the old Theranos building, so we're hoping to turn bad blood into good blood, if you're familiar with what I'm talking about. The radiochemistry labs are already open. The first faculty and scientists started working there, but this will allow us to install a 2nd cyclotron that will allow us to have access to more novel isotopes, and as well as to alpha and beta labeling for clinical and clinical research work. Moving on to equipment, we are big believers in PET-MR. The first one of its kind was installed in December 2013 for purely research purposes, then a 2nd one at the neuroscience building for adult clinical use, the 3rd one in the pediatric hospital, and the 4th one at the Veteran Administration Hospital next door to us. Similarly, we installed the first digital PET-CT of its kind, the SIPM-based PET-CT in August 2016. Our entire fleet of PET-CT scanners will be digital soon, so we're very proud of that. And of course, SPECT-CT is moving in the direction of being all digital as well. I want to spend a little bit of time on this different design of SPECT-CT. This is from one of the vendors who offers this. And why it's important? It's important because it's built so that you can image both lower and higher energy of the lutetium 177, be it DOTATATE or PSMA. And here is the same patient with a standard 15 minutes acquisition time, but also down to 5 minutes. And I don't think that you can see any degradation of image quality if you go to 5 minutes per bed. So keep in mind, 5 minutes per bed, okay? Now, this is the patient who was kind enough to allow us to scan him for dosimetry at 20 hours, 96 hours, and 144 hours post-injection of DOTATATE, both with the conventional SPECT-CT as well as the Starguide SPECT-CT. And I think that you can appreciate that maybe at 20 hours, images are very similar, but a third of the time, 5 minutes only. As you go far out, the noise level is significantly decreased with the Starguide compared to the standard, despite only using a third of the time. And now the even more exciting thing, I said 5 minutes per bed. What about 3 minutes per bed? This is a patient where for the first time, we can do SPECT CT faster than PET CT. So just think about that, okay? We have no excuse to not scan every patient that is coming to us for lutetium dotatate or lutetium PSMA treatment. It's another example again, 12 minutes post lutetium dotatate SPECT CT faster than copper 64 dotatate PET CT, okay? So again, as a community, no excuse to not scan these patients, either to document distribution of the treatment or for dosimetry purposes. We are also expanding our collaborations with our colleagues in radiation oncology. This PET-guided radiation therapy system. So instead of using the anatomy from CT or MR, Linacs, we are using the PET signal. So just think about it. A patient, think of the therapy trial, right? The famous and very well executed study here in Australia, excluding patients with FDG positive lesions from the PSMA therapy. What about giving them PSMA for the lesions that take up PSMA and then treating the FDG avid lesions with this external radiation therapy? Okay, we're just scratching the surface of what we can do here. Now, speaking of that, collaborations, this is just in the area of prostate cancer. At the top, my colleagues in radiation oncology, in the middle, medical oncology, and at the bottom, urology. Theragnostics is a team sport. You can only be successful if you play well in the sandbox. And I'm very proud to say at my institution, we are all collaborating greatly together to take good care of these patients. I also want to acknowledge my colleagues Gunilla Jacobsen and Bin Shan, who have been revamping our radiochemistry facility. We now have close to 40 investigational radiopharmaceuticals in use. And this a list of these radiopharmaceuticals, there are more coming. I want to spend a little bit on imaging angiogenesis. I think that this is a story that has been put to rest prematurely, and I hope that we can resuscitate it. Angiogenesis is critical for the spread of tumors, for metastatic disease, and we have many tools to evaluate it. Looking at alpha V beta 3 integrin, there are several PET radiopharmaceuticals, gallium labeled, copper 64 labeled, F18 labeled, monomers, dimers. The one that was developed and taken into patient at my institution is the FPPRGD2, a dimer. And we studied it to evaluate the angiogenesis and the response to drugs like Avastin in a variety of cancers. This is in breast cancer. The patient on the left has a lot of angiogenesis in the primary tumor. This is not seen with FDG. This is a lobular breast cancer, one that's difficult for many imaging modalities. Biopsy-proven axillary lymph node, biopsy-proven thoracic spine metastases that were not identified with FDG. On the other side, the primary tumor is not showing a lot of angiogenesis, so why would you give Avastin to this patient alone, while bony metastases demonstrate uptake? So an area that it's way underutilized in therapy. Is a patient with GBM with uptake prior to starting Avastin. As early as 1 week, you can tell that this patient is responding. The signal has decreased. At the standard of care evaluation 6 weeks after starting Avastin, the angiogenesis is gone. The MR signal has improved. This patient actually did very well over more than 2 years. Versus this other patient, signal of angiogenesis prior to Avastin that did not change at 1 week, that in fact has progressed at 6 weeks. So this patient did poorly, and we could have predicted this as early as 1 week after starting Avastin. Also want to mention this Notin alpha V beta 6. This was developed by my colleague, Dr. Richard Kimura, under supervision of late Dr. Sam Gambier. Alpha V beta 6, it's overexpressed in a variety of cancers, including pancreatic ductal adenocarcinoma. This has been published in both healthy volunteers and pancreatic cancer patients. As an example, on the left, the patient is Notin and FDG demonstrating very easy to identify pulmonary metastases with Notin, but not easily with FDG. Liver metastasis easily identifiable with Notin, much more conspicuous than with FDG. And if you look at the ratios at 1 or 2 hours, they're very similar, so you can image as early as 1 hour. My colleague, Dr. Henry Guo, allowed me to use these slides showing that actually fibrosis, which alpha V beta 6 is identifying, is overexpressed in long-term COVID. So this is the patient, healthy volunteer, no uptake in the lungs, IPF, a lot of uptake in the lungs, after lung transplant. The normal lung has no uptake, the diseased lung has uptake, and it's a patient 1 year after COVID pneumonia demonstrating significant fibrosis ongoing in both lungs. So there is increased lung uptake in these patients, and the uptake is statistically significant between the normal and abnormal lung. These are how these changes are looking on CT, so they can be difficult to determine whether they're still active or not. With not in PET, you can tell what's active very easily. Another very interesting research project from my colleague, Dr. Eben Rosenthal, head and neck surgeon. How do we increase the sensitivity and specificity of FDG for head and neck squamous cell cancers? Well, how about labeling panitumumab with zirconium-89? And this is the study that has been done. We want to see if all the lymph nodes that we see as FDG are actually diseased. There are many false positives. And we feel that although the sensitivity may be similar, the specificity is definitely increased if you add the zirconium-labeled panitumumab to the workup of these patients. We're also using an indium-111 labeled panitumumab to guide surgery. So the surgeons are using that and a gamma probe during surgery to remove only the lymph nodes that are involved by disease. And this is a patient immediately after injection, just like with every antibody, a lot of blood pool activity, but then as we wait longer and longer, you can see the primary and some of the lymph nodes lighting up. Speaking about specificity, this is a great example because in addition to the primary and some of the lymph nodes having uptake, you have degenerative changes in the right shoulder as well as some infectious disease in the lungs, and you can appreciate here that some of the lymph nodes do demonstrate uptake with the panitumumab. However, there's nothing in the area of the shoulder, so it's just reactive with FDG, and there's nothing in the lung infection that takes up the VEGF receptor panitumumab. So a very exciting, just one of the many projects that my colleagues are working on. One of these exciting projects is PKM2. This contributes to altered glycolysis, and this is F18-DASA23's tracer that was developed at Stanford. My colleague Corinne Baynard worked with Sam to further develop this radiopharmaceutical. You can see its biodistribution from immediately after injection up to 3 hours. And you can see how it clears from the blood and how it concentrates in lesions. Normal brain will have very low uptake. However, if you look at glioma, GBM in this case, there is a lot of uptake there. And my colleagues are not working just on identifying the disease, but also identifying the response to treatment. So this is a pre-therapy scan. These patients are getting temozolomide and Avastin, and you can see the changes. These are all patients that were done in the same day as research. It was fantastic, but very stressful. So I hope I don't get to see this very often. 2 of them are already FDA approved. But just it goes to show how much work is being done for our field currently. We're also giving back to the community. Pre-FDA approval, we scanned more than 750 patients, and through resources of the department, private donors, foundations, we're able to not charge these patients. So if they went at another institution, they would have paid $2,000 to $3,000. If they came to us, they would have had this scan at no cost. And this is showing that here, if the patient have to pay, then minorities such as African Americans have a much lower access to the research scan versus when they don't have to pay, when their access is similar between the standard of care and the research scan. I will end with the people. This is the most important thing, and it starts with our young colleagues, our trainees. Stanford established the first of its kind combined nuclear medicine and radiology training in the United States. This program asks for 1 year of internal medicine or surgery, 1 year of nuclear medicine, 3 years of radiology, and the final year in nuclear medicine. And I'm not saying that this is the best thing for everyone, but I do think it works well for us, for our trainees, and for preparing people for the academic environment of the future. People who come to Stanford then go back to their institutions, and there are many people throughout the world who experienced the molecular imaging program or the nuclear medicine program at Stanford. This was Sam's dream to share the knowledge worldwide and to advance our field. The Theragnostics Clinic is led by my colleague, Dr. Karina Maria Paricci. We also have a nurse practitioner, Kat, a physicist, a radiochemist, a lead technologist, and a clinic coordinator. And of course, all of us are helping in this clinic. We see patients in visits prior to treatment as well as after each cycle of treatment. Our team has grown significantly over years. At the top are my colleagues on the adult side. Helen leads the pediatric program, and then George and Milal lead the veteran administration program. Okay, I want to acknowledge some of the colleagues who worked on these projects that I mentioned today: Lucia, Corinne, Guido, Hein, Valentina, Henry, Farshad, and Hong. I also want to thank many people in the community worldwide who assisted us, particularly Professor Mackey, who anything that uses bombacin probably came out of his lab, whether it's RM2, RM26, others. So many thanks. And of course, the group in Germany who generously allowed us to use data from their studying of PSMA11, and the team at Bayer sharing, Ludger, Andrew, Marion, Andrei, and Matthias for supporting our work with RM2. This is the funding coming from Bayer sharing, Piramal Life Now, the Department of Radiology, the Department of Defense, the National Cancer Institute, Lantheus, and GE. And I will end with, you know this very well, but I cannot not mention it. These are the multiple steps that are involved, even with the simplest of the things that we do with FDG. We perhaps don't think of it like this anymore because we just expect it to happen every day. But maybe for our colleagues from oncology or surgery who don't know how complex our workflow is, look how many steps are involved. And what can go wrong? Well, everything can go wrong, from materials, and with the COVID pandemic, even plastic tubes are sometimes troublesome to find. The equipment, the process, something can fail. The quality control, we're bound to very, very tight regulations. And of course, we don't want to have any of these, but they can happen. So with that, I want to thank each and every of my 60 plus colleagues across our enterprise who work in nuclear medicine for all they do on a daily basis for our patients, for research, for education. I'm so proud to work with all of you. And I want to end with a few words about Sam. Sam and Aruna really loved coming to Australia. The picture on the left was taken in Tasmania. The picture on the right was taken in Melbourne. I had the pleasure of being here with Sam in the 2016 meeting, as well as a couple of years later. And I cherished every moment, just like you all did, if you knew Sam. When we opened our Theragnostics clinic last May 2021, Aruna kindly joined us, and she reminded us that Sam could have been a patient. He could have benefited from this. So we always think of every patient that we have as being Sam, and we take care of every patient that we have as if she or he would be Sam. And for us as a community, if you did not listen to Sam speaking at 2018 SNMI meeting in Philadelphia when he received the major award, that recording is available online. Listen to it. It's a very personal story that he's telling. It's also ending with this advice to treat each other with respect, as if we are family. And that's how I like to think of all of us, that we're part of this wonderful nuclear medicine family, and we're very respectful of each other. With that, thank you again for the invitation to be here. I thoroughly enjoyed the meeting, and I look forward to many more collaborations between nuclear medicine worldwide. Thank you.